Hello, welcome everybody. Welcome to this edition of the Cameroon Town Hall for Healthcare Professionals. You're all welcome. If you are joining us for the first time, this is a platform that brings together healthcare professionals from Cameroon origin who are spread across the world. I always try to update us with the statistics. We are still in 36 countries and the number has grown to 2,100 participants. That is those who have been able to attend at least one session of the town hall. Once again, you're welcome, and I hope you had a very enjoyable week. We shall be having a very exciting topic today as usual. But before we get on, let me greet our co-moderators and get a word from them. I will start with Dr. Brian Tegomo. Hello, Brian. How was your week?
Yeah, very busy week. Yeah, it's always great to see you, see everyone, and welcome to everyone. It's always a pleasure engaging in these conversations every other week. I think a lot has been going on across the world, particularly this week was just the closing of the UN General Assembly. So lots and lots of interesting discussions around the issues, lessons learned from the last 3 years, particularly in terms of pandemic preparedness and things like that. So it's wonderful opportunities for global leaders to come together and have those very strong conversations. But also today, I'm really excited for the discussions today on maternal health. I think it's a very important, critical subject, particularly in Cameroon, where we're still suffering from. I was just looking at the recent statistics, Elvis, on maternal death numbers, the recent numbers on WHO, and I was really staggered by the statistics. So it really looks like we still have a lot of work to do. So I'm thrilled to hear more about these innovative programs like the top pregnancy that Dr. Gwanyama has, and how that platform can be leveraged to improve some of these statistics. So looking forward to the session today. Over to you, Elvis.
You're quite interesting, Brian. And as you know, maternal health is very important to me. That's one of the mission of Unite for Health Foundation. And we all acknowledge the fact that Cameroon is still one of the highest contributors of maternal mortality globally. So we have a lot of work to do. That's why when we have people like this who are creating impact in their own ways to improve maternal health, then it's very important to the town hall. Hello, Dr. Kate. Welcome to this session. I know you have from a very busy week, haven't had a very important conference on the NCDs. How was your conference and how was your week, Dr. Kate?
Thank you very much, Elvis. I actually am joining late and really was not thinking that you were going to pick on me. But I think we had a very interesting meeting, Act on NCD, that was on the 20th with the Cameroon NCD Alliance and the RADA Association based in Bamenda. And there were key stakeholders attended the meeting with 2 breakout sessions, and they were really we were really in the meeting trying to draft an agenda on how to put NCD on the forefront of our strategy for health in Cameroon, especially universal health coverage. And so it was a very fruitful meeting, and we hope that the minutes and the points or take-home messages from the meeting will be adopted. And I also do look forward to hear from Dr. Gwanyama and Noella, and that is why I joined even after a very busy Saturday.
Yeah, thank you very much, Dr. Kate. I agree with you, and the work you're doing to put NCD as one of the very important elements of health that should be taken serious by the Cameroon Ministry of Health is very important. Last week, I was also in New York City and attending one of the side events of the UNGA, which was on chronic kidney disease. And what came across in that event was the importance of NCDs and forming these kinds of alliance. I think this year there has been an alliance of chronic kidney disease that has been formed by 17 different organizations from 15 different countries. And so when we see all these kind of alliances being formed around NCDs, it's a very, very important move. So thank you for all the work you're doing on NCDs in Cameroon with all your network there. We will be getting to hear from our own chair, Dr. Mono. Hello, Dr. Mono. Welcome.
Yeah, thank you, Elvis. And I just want to thank Noella also for her time and for accepting our invitation. And also to say a big thank you to Dr. Jean-Claude Kate, who actually represented the town hall in this discussion. And I think as time goes by, we may have a session in order to share into what you guys discuss and to see exactly how the town hall can help and leverage with that discussion that you had about NTDs. It's been a very important time to really get to talk about non-communicable diseases, not excluding cancers, please, guys. So it's one of those things that is, it's the big elephant in the room because there's no research. I'm trying to advocate for my field. There is no research and there is very little knowledge. So I am planning on the town hall organizing a side-by conference really in October, really it's going to be more for practitioners, nurses, doctors, even anyone who is interested. We're going to do a 4 session. I'm going to get to Elvis, but it's not going to be on Saturday. We'll not take the time of the town hall, where we're going to educate those who are practicing home, discuss, have shared decisions on how to, October is Breast Cancer Month. So we want to use the World Breast Cancer Month and discuss the proper management of breast cancer and how we can manage breast cancer in Cameroon. I'm just letting this out there. And I think we'll be able to organize a 4-session workshop where we can really talk about this and get to deal with one of the elephants in the room. Breast cancer is the #1 female cancer in Cameroon and #1 even among all cancers, and it's underdiagnosed and diagnosed very late. So Elvis, I just wanted to let you know about this, and the rest of the town hall moderators will look for a different date and time where we would use the platform in order just to help with education concerning this. So Noella, thank you. And maternal mortality has been, Dr. Ombaku Kingsley is here and is one of my partners, which we did a lot of work on maternal mortality and did some little work and tried to see how we could reduce this. And he's a gynecologist. And I think he's still doing that work. And it's one of those wonderful things that Cameroon can leverage on and really improve. The statistics are sad, deplorable. I hope we can improve. We have actually gotten worse than how we were in the 80s. So that's one of the things that we need to emphasize on. So thank you.
Thank you very much, Mona. And that's going to be an initiative of the town hall, but he says we're not going to take a Saturday town hall time. So it's going to be a practical session, very educative, and we're going to lay out all the program and send out an email with regards to that very important event that is coming up in October. Before we get to our main guest, I think we have some people I would just like to get their thoughts on the topic. We have our own Dr. Ronald Kobina, who is a nephrologist in the Southwest region of Cameroon, who has joined us in town hall today. Hello, Dr. Ronald. You're welcome to the town hall. And what are your thoughts about the topic of today?
Hello, Elvis. It's very on point. I can't wait to have the keynote, and then we'll have discussions.
Great, thank you very much. I know you are doing a lot in the Southwest region as far as kidney disease is concerned as a nephrologist.
Thank you.
So congrats for all the great work you're doing. And today our guest is Dr. Noella Gwanyama.
Thank you.
And she is a medical doctor in Cameroon with about 5 years of experience working in the regional hospital in the Northwest region in Bamenda. And she is a Mandela Washington Fellow. She just finished a very interesting program where she studied at Delaware State University here in the United States under civic leadership through the Mandela Washington Fellowship Program. Noella is a social influencer with about 20,400 followers on YouTube. She started a program, Talk Pregnancy with Noella, where she has been educating and answering questions around the subject of pregnancy. And amazingly, when I came in touch with Noella, I thought maybe this was just for Cameroonian pregnant women. Then I got to realize that people are following Noella from so many different African countries, from Ghana, from Nigeria, from Ethiopia. She answers questions from women across Africa who tune to her YouTube page to see and follow all the different episodes of Talk Pregnancy with Noella. We are so thrilled to have someone who has chosen social media to educate pregnant women on pregnancy and pregnancy outcome as a way of reducing maternal mortality. Thank you so much, Dr. Gwanyama and Noella, for accepting our invitation. And we look forward to get a presentation and have some question and answer session with you just on what inspired you to do this work and what are the challenges and what do you think that others can benefit from this kind of initiative. So I'll hand over the floor to Noella for her presentation, and thereafter we're going to have an interaction.
Thank you very much, Evis. Thank you very much, Dr. Mono, and everyone for actually giving me this opportunity to share my story. So I'm just going to share my slide. Sorry, the light has just...
Yeah,
that's a reality in
I'm happy you told us before time to be ready to share your slide. So you can send it to Mono, can be able to share the slide for you.
Yeah, I think I've sent it to him.
All right, good.
Let me send you a text because I've not seen it so that.
Okay.
Yeah, so you can get my email.
While Noella is setting up, I would want to just get some few thoughts and voices in the house, and want to hear Fond Samuel. Hello, welcome to this edition. Just a word from you as we set up the slides.
Oh, good evening, Dr. Elvis. Can you hear me, please?
Yes, we hear you.
Oh, I'm Fond Samuel, a medical student at Bamenda and a great lover of what the town hall has been doing, and I've been attending a couple of sessions for the past months. And I'm very happy to learn from Dr. Noella today. Thank you.
Thank you, and I'm always happy that you attend and you participate. So thank you for always trying to find time from your busy schedule as a student to attend the town hall. We're really glad to have you. And we can hear some few words from Gael Sandra. Hello, Gael. If you're speaking, you're on mute. Okay, we didn't get Gael, but I think we are about to get the slides and we should be able to get Noella start her presentation. But before then, I think we have our own Professor Gacho in the house. Hello, Prof. You are speaking, you're on mute.
Okay, so yeah, Elvis, I've still been unable to have the slides right now. I'm just checking.
Okay.
Yeah, Noella started sharing. Okay.
Yeah, but it's we have a blank slide. Hoping that she's able to.
I don't know. Can you see?
No, it's
Is it okay?
It's a blank slide.
It's happening. Let me see.
Chris is in the house. Hello, Chris.
Let me see. Stop sharing.
Hi, Elvis. Good morning to everyone.
How are you today? And which part of the globe are you now?
Currently, I'm talking from Calgary in Canada.
Oh, great.
Yes,
Great.
we can see your slides. You can put them in the, yeah, good.
Okay.
All right, and then we can give you the time, Noella. So take it away from me.
Okay, thank you all so much. And I'm going to be talking today about how I use social media to improve maternal health in Cameroon. And this is going to be talking about Talk Pregnancy with Dr. Noella in all aspects. So this is the plan we're going to follow. So before I want to introduce what maternal mortality is all about, I always start with this story. I always like people to get the picture of what maternal mortality is all about. We know we are all health professionals, but if we put it in a certain way, it's going to make people look it differently. Imagine your sister or your mom or your wife goes to the hospital to go and deliver, and you've arranged the bed of the baby and you've arranged her own bed, and she delivers and she dies. And she's not able to carry that baby. So that picture, if you put that in your mind, that's when you're going to actually see what maternal mortality is all about. So even before coming to the definition, I always like to bring out this scenario so that everybody can picture it out. So normally is the death of a woman while pregnant or within 42 days of termination of a pregnancy, irrespective of the duration and the site of the pregnancy, and from any cause related to or aggravated by the pregnancy or its management, and not from accidental causes or any incidental causes. I think many of us know about this. So it's mainly, even it's an ectopic pregnancy, it's just 1 month and she dies because of this pregnancy. That is maternal mortality, and 42 days after even the termination of this pregnancy. Now, what's the global burden of this maternal mortality? We need to, at least once we know the burden, we're going to see how we can, or how the use of this media and other aspects of top pregnancy, Dr. Noella has been able to address this. So if we want to take the statistics from 2000 to 2020, we will see here that around 340 something women died in 2000, and in 2020 we had almost 223 maternal deaths. But now globally there's actually a decline, but the global maternal mortality rate stands at 210. But this is still high, because the target for the Sustainable Development Goal is 70 deaths per 100,000 live births. So imagine where we are still, 210, that's still high. Now, if we put out this scenario again, it tells us that every 2 minutes, 1 woman dies because of a preventable cause. It's a preventable cause. That's the first thing we should know. Every 1 hour, that means 30 women are going to die. Every 2 hours, 60. That's unacceptable. So it's something we should be spoken about, and something really has to be done. So if you see 99% of this actually occur in developing countries, and now we have the effect of COVID-19, and maybe trying to see the maternal mortality rate before COVID-19 and after. But the effect of COVID on maternal mortality is not yet really possible, because only about 20% of countries have submitted their data for 2020. So that's why they really can't give a concrete difference between before COVID and after. Now, when we come to Cameroon, we see here that in 2020 and 2000 and 2020, we had almost around 650 something deaths. And in 2020, we had 438 deaths. That's according to the World Health Organization. Now we also have presently a maternal mortality rate of 406 deaths. Like I said, it is still very high, because our target for the Sustainable Development Goal is 70 deaths per 100,000 live births. So we still have work to do. And if you see the maternal mortality rate is still high in sub-Saharan Africa, especially in Cameroon too. Then women, if you want to see the rates, the percentage of childbearing age, the women of childbearing age is 23% in Cameroon. So this is one of the statistics of the Northwest region, where during a perinatal network training, where it was presented, if you see the number of maternal deaths, that's the first column, is 46, and the highest was in Bamenda, followed in Bamenda Health District, followed by Oku and Womb. So those are then the next one follows. So you see, these are the number of maternal deaths in 2021 in the Northwest region. Then this in the regional hospital, this was one of the annual reports of activities presented in the regional hospital. I'm also part of the maternal mortality and neonatal mortality death audit team in the regional hospital Bamenda. So we actually have first-hand information on what is happening. If you see here the effect of the crisis and COVID-19, if you see in 2018, we had a total number of 6 deaths. And if you see 2020, that number doubled. And if you want to see, that's actually after just when the COVID was entering and also almost around the peak of the crisis. So here we had a double number. So we see the effect of COVID and also the effect of the crisis. And now it has actually been reducing with many aspects being put into place, many health personnel being trained, and many awareness also available. Now coming to what are some of the causes of these maternal deaths, where I actually target people, where I actually do the work. If you see, there was a study done in La Cantini in 2017. It was just published, I think it was just July. It was just published July. So it showed a maternal death of 116 from 2017 to 2022. And the total number of women who did not attend antenatal consultations was 19. Then the percentage was 11.4. Now in Central, there was another study which was done in Central Hospital Yaoundé and the Yaoundé Gynaco Obstetric and Pediatric Hospital. The maternal deaths were 115. Then you see the number of antenatal consultations. The women who had no antenatal consultations, see in Yaoundé Central Hospital, that was 69. That's 44.5. That's almost 50% of women who died did not even attend antenatal consultation. In Yaoundé Obstetric, it was 37.7. So we see here that the use of antenatal consult, the importance of antenatal consultation. So that is what is going to bring us to, okay, what are the main causes of maternal mortality in Cameroon? The main direct causes of maternal death in developing countries include hemorrhage, sepsis, obstructed labor, and hypertensive disorders. And with hemorrhage, it means it is identified early. There are women who have high risks of getting into hemorrhage. So this is actually identified during ANC. Sepsis, for example, like for maybe abortions, which have been done, that's clandestine abortions, obstructed labor, hypertensive disorders, all these can be catched during antenatal consultations. So these are some kind of things which can actually be caught during antenatal consultations, whereas there are up to 50% of women in some areas not attending antenatal consultation. So now, what can we do to prevent early diagnosis of pregnancy? Good ANC associated with maternal health education and access to skilled personnel are important factors to reducing maternal mortality. So now, what is my story? What happened before I came up with this Stop Pregnancy with Dr. Noella? I was pregnant for my first pregnancy. I was working actually in the the maternity section, and I was pregnant that time, and everything was going on well. I did my normal ultrasound scan, and the last one I did it. But now, seeing what women went through, seeing the kind of complications that can occur. There was one time I just saw a woman who came at 40 weeks, and she said she's not feeling the baby kicking. I wanted to check the baby was macerated. It means the baby had died since. So she didn't even know danger signs in pregnancy. She didn't know when there was a problem. So this, or maybe she could have had a better way to tell her what, or something better. So with all this, I was like, okay, I'm at 9 months now. So let me just go now and maybe prepare for my delivery. But something clicked me that let me just go and check for the last time. That was just from, like, let's say from my experience. I said, let me just go and check for the last time and actually see what, and make sure that everything is fine before labor starts. Unfortunately for me, the ultrasound, the sonographer told me that there's a cord around the baby's neck with a knot already formed. I was like, you know, when it's happening to you, when you're on the other side as a health personnel, it's difficult. You might start you have this feeling like, is this me? And as I was working in the maternity section, it was like, oh, this cannot be happening to me. So I was asking him that, so what next? He said, just go and meet your gynecologist. So when I went and met, it was Dr. Piso and Dr. Takang. These are the two of them here over there doing the surgery. So, and those are the theater staffs encouraging me, because it wasn't really easy as a medical personnel. So after that, they just in almost like 30 minutes, going to 45 minutes. I mean, everything was done. The baby was fine. And I was also fine, even though I suffered some complications of spinal headaches after, but I think everything went on smoothly. So I was like, this happened to me as a medical personnel. How about those women out there who don't have this equal and quality access to health services during pregnancy? Imagine if it was something that had to really, which was a threat to my life. I think I would have had an early access to healthcare, which will actually prevent any mortality at that stage. So I had to come up now with Talk Pregnancy with Dr. Noella. And from there, this when I had to come up with these like 9 facts, because everybody in my family, they were like, huh, operation. So it means that all your pregnancies are going to be by operation. What happened? Doc, even you could not push. So I was like, please, what's happening? That was a complication that occurred, and I had to just do it to save the baby. So I started listening. I said, but if the people around me are having that kind of perspective, what more of other people? So I need to start educating people. That was when I started with the YouTube channel, having where I started talking about the 9 facts to have a vaginal delivery after a cesarean section. And from there, I've been able to follow up a lot of women. There was one girl who actually came to me and said they told her she had a complete placenta previa. So she was so traumatized. So when she came and spoke to me, I told her everything about this, but she did not believe until when I told her that, can she believe that I was operated? She said, hey, doctor, you operated and you are fine like this. Hey, it means that I'll no longer be afraid again. And that was how she calmed down herself and accepted the procedure, and everything went on well. So now I also started a Facebook page. This was actually where I started, from having up to now 3,700 followers, where I just give information about pregnancy, about some common complications during pregnancy and what you can do. I was just giving a general idea about pregnancy to help sensitize women about pregnancy. So now what I did again was I made like online classes, over like how many series of online classes to help women with their menstrual cycle, because most of them, there's another cause of maternal mortality is unwanted pregnancies, where they tend to go and have induced abortions, and it gets into sepsis or bleeding and they die. So in order to prevent these unwanted pregnancies, I trained over 200 women on the mastery of their menstrual cycle. So we have like a closed group where each of them actually give their various dates. I help them, we calculate together. Those with irregular, we try to see how we can calculate, and we've had really good results with that. Then secondly, this is not only about me or me as Dr. Noella. We also collaborate with other doctors. Like, I had a lot of patients coming to me complaining about infertility. So it was too much. So that's where I had a concern now that, hey, it means that infertility too is another problem. So what can we do? How can I help them? That's when I brought up Dr. Piso, Dr. Dobgima, who came up during our Facebook Live and actually discussed everything about infertility, the different kind of infertility, the various causes and the various management. And here we reached over 670 people. And believe me, we had 10 women who actually came to consult us at the regional hospital. Some even came from, from other parts of Cameroon, other regions. There was actually this one from Bafoussam, benefited from a laparoscopic surgery, and which is done at the regional hospital, and Dr. Piso actually was the one who did it for her. So now also with collaboration, we know that medicine now, many people tend to take other drugs from any kind of maybe pharmacies, or they don't know what to take during pregnancy. So I had to come up with Dr. Yuba Marie, who is a pharmacist. I also called her up to come for a live session where we reached over 600 women. And if you see, these are some kind of questions. Somebody will ask, oh, doc, no alcohol. You say, what about the natural alcohol, like raffia wine, like palm wine? How does it affect? So these are some kind of questions that people ask, and we see how we can actually educate them more so that they can have a safe pregnancy and safe delivery. Now, this is the YouTube channel which I started, and I started just last year in February 2022, and we're having almost going to 900,000 viewers with 20,400 subscribers with 46 videos posted. This also TikTok, which I use. So I use all the social media platforms to actually educate. This TikTok with almost getting to 30,000 followers already. So with the dancing and all that, sometimes some doctors will say, hey, doctor, those dances. So it's really amazing. And when you get the feedback from what people are really getting from there and actually learning, so you know that that's what you have to do. That's the impact you have to create. So going to that, apart out of the social media, from there, when we then got the ground, we knew now that, okay, what can we do on ground? How can we help other people? Or this, now we are having IDP women. I had them in front of us, in front of me. They cannot continue the antenatal consultation. So I was like, how can we do that? We solicited for funds, applied for some grants, and this is when we actually came to present some our proposal to the director to tell him that, okay, we have some 10 IDP women and we want to help them throughout their pregnancy for antenatal consultation so that they can have a good follow-up, and any complications we're able to identify it early and manage them early. Out of these was one girl who came at 7 months, and most of them, these were 10 IDP girls, some of them had not started antenatal consultation at 7 months, so we're able to start them at that 7 months. And there was one at that time, her HB was around 8. So we had to see how we increase her iron tablet to make sure that during 9 months, her blood level has gone up. So these were some kind of the impact that we created on these women. So we actually get into them and help them. So in that case, increasing the uptake of ANC. So this is actually another case of a rape girl. So in the hospital there, I made it known to everybody. Everybody calls me top pregnancy, top pregnancy. So once they see anything in a way, they see any desperate case, they just come and meet me and say, doc, how can you help this woman? So in the hospital, in the regional hospital, what do they do with cases of rape? They just give them the first aid or management to prevent any infection, and psychosocial support and legal support. But if you become pregnant out of that rape, they don't follow you up for that. So that was when they came with this girl. This is a 14-year-old girl who came, and we actually followed her up throughout her pregnancy. And at the end, she actually delivered by cesarean section. And if she was not really followed up, maybe she would have gone to another hospital, and maybe we don't know. But at the end, she had a cesarean section, which I think it was good at her age because she was 14 years old. Then doing like preconception care too was another aspect which because we believe that if you're reading a book, for example, it's like to know what is ahead, so that if there's any complication, you already know how to handle it. If there are any challenges, you already know how to handle it. That's where we came up with this preconception care. That if everybody knows what pregnancy is all about, the difficulties, that anything can happen at any time, changes can occur at any time, it's going to help them prevent what? So it's also going to expose you to know your menstrual cycle, it's going to expose you to family planning. So it's also going to expose and increase the uptake of family planning, and also improve your early diagnosis of pregnancy and complete follow-up of pregnancy. So we also use this as a means to help in premarital screening. So that's where most of the things can be done. This is an example of someone who actually came to my inbox after the session. So she knew that this is what I'm asking for, this is what I usually talk about. So she came and asked me for the various tests that can be done before she actually gets married. So I gave her this and she did it and it was fine. So it was actually a positive impact. So what do I do? Before I want to carry out a campaign, I use the social media. I put a flyer. If you're in Bambili, if you're in any place, if you can come, I go to the radio, this CRTV Bamenda, I go there, I talk, I tell them, I educate them about everything. Okay, I want to carry out a campaign in this place. If you're available, you can come. So this was in Bambili, there was a campaign in Bambili where we help and educate people on proper pregnancy follow-up and importance of premarital screening. This also reaching out to people with disabilities, educating them about the use of contraceptives. And after this, there was actually one woman who came the next day and took a family planning at the family planning unit. So it was really impactful. These are other examples. These are some grants which we have received, like the European Union Fed grants. This was what we used to help that pregnant woman because it's a case of GBV. So they gave us grants for GBV cases where we educated people and we used and helped that woman, that 14-year-old Muslim girl. We have also had just recently the Aviva Women in Science Fund, and I'm the first person to actually receive a funding from these people, which I'm going to help to train community health workers, nurses, and doctors in womb to actually identify high-risk pregnant women and refer them. Happy Mother. So these are some listing. So some awards which I've received: the Mandela Washington Fellowship, the best elevator speech at the University of Delaware, where you're able to present yourself for 60 to 90 minutes and giving the impact of your work. So that's when I spoke about maternal mortality, and I won the prize, and the most assertive person and always ready and an achiever to get what she wants. So these are some other honors, and this was me and CRTV Yaoundé, where I was there interviewed by Muki Edwin Kenzeka on sexual and reproductive health. And I'm also part of the hospital doctors. I have a page too there where I'm also educating women and they are able to talk with me directly. So what's the way forward to maternal mortality? Now, it's something that we should start from the beginning. We should not wait, let the complications start first before we work on it. So the first thing is collaboration between government, between stakeholders, non-governmental organizations, using the media, increase awareness on preconception care. Like I said, if every woman knows what pregnancy is all about, what they can do in the long run, once they get pregnant, what should they do? Before I want to get pregnant, what should I do? It's going to prevent infections, prevent mother-to-child transmission. So once preconception care is something in the brain of all women, I think it's a beginning to a better future for women. Increased uptake of ANC, that's very important. We have seen that in Cameroon, it is really, really low. So awareness campaign, trainings like what I want to do now, because we put people to be aware that there should be no woman that they see in their community, health workers, community health workers. They should not see any woman in the community who is pregnant and has not gone for consultation. Carry them and bring them to the hospital. Even they cannot pay, you start seeing what they can do, but carry them first and take them to the hospital. They should just educate them, let them know. Then subsidized and free ANC. If we can do this one, we're going to help. Universal health coverage is coming up. I hope they're going to consider women to give them free ANC such that any complication is going to be identified early and managed early. Reconstructions of health facilities which have been burned down. So we envision a society where every woman is given an equal opportunity to hold her baby after delivery. Thank you very much for your kind attention.
Wow, this is really amazing. Thank you very much, Dr. Noella, for this wonderful presentation. It's really been great. Thanks a lot for, it's really emotional, but also very important. A lot of lessons learned. You can stop sharing your screen so we can have engagement with the audience. And I'm sure everyone is as excited as I am. I see Toka Robbins, who is an American, but who always joined the town hall to follow up what is happening. And Toka Robbins, I'm sure it's going to force blood in your heart to hear that Uku, which you love so much, is among those health districts in Cameroon with the highest maternal mortality in the Northwest region. What's your reaction about that? You are mute, Toka. No, we can't hear you. Maybe you have to unmute yourself.
Yes.
It was very exciting to hear the education you're doing, the caring for mothers, and to create these bridges of sharing education, sharing knowledge, sharing compassion and love, so that those mothers can be with their babies. And it's instrumental to both Elvis and our efforts in Unite for Health Foundation. So it's very exciting to hear all that you've done and created connectivity. So very much aligned with my spirit and my hopes for Oku and Bamenda, the Northeast Cameroon. May there be peace so that we can care for the children there. Thank you for your good works.
Thank you very much, Toka. And Toka is one of the board members of Unite for Health Foundation, and he spent over the past 30 years, he's done a lot of visits to Cameroon, and he's passionate about everything that happens in the country. We've had a very, very exciting conversation and presentation from Dr. Noella, and I'm sure everyone is bubbling up with a lot of questions. But I saw our chair was really keen during this presentation, and I know when something touches his heart, I can always see on his face. Hello, Dr. Mono.
Oh yeah, Elvis, and this has always been one of those topics which I will tell you, this is what made me to do medicine, though I'm not a gynecologist. And the day I went for specialization in Yaoundé, which I disappointed one of my professors, Professor Mbu, asked me what I'm coming to specialize in. And I told him I'm coming to do OBGYN, which I was not telling the truth then. And I registered for clinical pathology. Now, when I passed the entrance and I went for orals, he met me there and he's like, Kenny, this is formal. This is not the right thing to do. You know, your mother helped train me. So my mother was in charge of the maternity for many years. The reason I'm bringing up this story is that you could be in charge of maternity and still, like Dr. Noella said, her story. I got my mother's permission just a few minutes ago, though she's now having a stroke and not willing to talk, to share her story too. She was in charge of the maternity and later on became the general supervisor of the regional hospital. That's before Noella ever went there. And during her last pregnancy, I was in school. I was a young boy. My mom, my father, everyone had prepared everything to receive our youngest sister back home. Everything was going well. She is one of those people, those who have worked in the regional hospital will tell you she used to be a very lively person and the whole market knew her, like everyone knew her, and everyone still does. So she gave birth to my younger sister. After that, she developed she developed eclampsia, actually postpartum eclampsia. At the time, she would have died if one of her colleagues, who was also the former charge of the maternity, was not observant enough to have seen that. She went home after discharge. She came to check on my mom. Blood pressures were in the hundreds, 200s. Her legs were all swollen. She ended up in the, what they call, that's our, how do they call it still now in Cameroon? The ICU, or what they call the intensive care. She was there for exactly 3 months. Yes, 3 months. My mom was in the intensive care in Bamenda Regional Hospital for 3 months. Transported to Bafusa multiple times for multiple interventions. And she ended up after that unable to hear in one side of her ears. And she later on, after all of this, she was still in charge of the maternity and the education around them. Just to tell you that it doesn't spare anyone. And this was one of my primary motivations, because my elder sister, who is also a doctor, used to leave Lourdes and come to the hospital and cry every day. So maternal mortality is very special to me. Women do die out of giving life. And it's very emotional when it's your mom. It's very emotional when it's your sister. It's very emotional and different when it's you. So we need to be able to do everything possible. And I would love to really hear, I have a friend here who is an obstetrician and gynecologist who joined, who is also in the regional hospital with Noella, Dr. Ombaku Kingsley. Ombaku did a lot back when we left school in order to, he wrote a lot of papers, a lot of projects, even some of them were used nationally. I know a lot of people don't know that when Professor Mbu was in charge of the mother and child health, and a lot of those projects were used nationally, because Cameroon, in the 80s, our maternal mortality was similar or even worse in the 90s. As Noella showed you, it has been going down from 600, but in the 80s, it was better. If you look at the statistics, it was kind of better in the 80s and got worse. Cameroon stopped training all its midwives. My mother was a trained midwife in the 80s and the 70s, sorry. My mother was trained in the 70s as a midwife, but there was no midwife training in Cameroon for more than 20 years, Elvis. A gap. There was no training of subspecialty. So I'm just ranting all of this, but please, just to let you know, this is a big passion of mine, and I don't want to take the time of Noella. I'm happy the lights are back, so she's not going to be cut in any way. So the 4 T's, which there's the delays, the 4 delays of maternal mortality, which I actually learned about these delays. I went to medical school, but Ombaku was one of those who used to talk about the delays, how to seek for care. How do we have reaching out for care, even the things that avoid. And once you get to the hospital, receiving adequate care. And once we have lack, the last one is lack of facilities, responsibility from the healthcare workers themselves. So I'm not going to spend, let me give the mic to others, but I just wanted to share my mom's story, saying that you could be part of the problem, trying to solve the problem and become a problem. So no one is spared out of this whole thing, no one.
Quite a passionate story there, Dr. Mono. Thanks so much for sharing that story. And I'll go the rounds with the other moderators. Dr. Brian, how's your take of the presentation?
Thanks, Elvis. I thought it was great. I was really struck by the first slide where she shared a woman dies every 2 minutes, and her presentation, and we've been on this call for about 50 minutes now, and approximately 25 women have died that didn't need to die as a result of the issues around maternal access to maternal health. I see Dr. Asensio in the chat has mentioned really a wide multidimensional factors that could account for some of those issues. And I hope we can, during the discussion today, we can discuss and see how we can support initiatives like Dr. Noella's initiatives in resolving this issue. Really, it's a really important global health issue. So over to you, Elvis.
Really important global health issue, because I mean, considering that 43% the population in Cameroon is of women of childbearing age. So we are talking about a very important demographics here that we have to pay attention to. So let's get to Dr. Kate. Hello, Dr. Kate.
Yeah, thank you so much, Elvis. I've really just been following quietly. Unfortunately, I can't put on my camera for you to see me tearing after listening to Noella's presentation. Really, I do admire what you're doing. This is true community and public health action. And education is one of the cheapest public health intervention that we know works all around the world. And it's just so amazing why we do not have lots of funding into education. I myself, the first person I saw die, as a medical student, I was in the 3rd year, 2007. That summer holidays, as some others will call it, Bongé District Hospital, no light. I was standing outside and I saw a pregnant woman walking up the hill towards the hospital with the husband, and somewhere in the middle, climbing the hill, she started convulsing. And by the time we ran, as I was a 3rd year medical student, I was just visiting that locality, and I decided to pop to the hospital. And it was a dreadful thing for me experiencing that as a young medical student. That was the first time I saw someone die. She actually, died in the hands of the husband and myself and others who were there trying to help. So this is real, and just education can dramatically change the outcome. And I'm sure, Noella, you would never imagine there's so many outcomes that have already been changed by what you're doing. Thank you very much.
Thank you, Dr. Kate. This is truly real. And you mentioned education. I'll take one last comment before I hand over to Dr. Brian to moderate the question and answer session. And we have Dr. Samuel, you own a health facility and you've been doing a lot of humanitarian work in Cameroon in Dub. And Noella cited one of the studies that was done between 2017 and 2022. And in one of the studies in the Central Hospital in Yaoundé, which was one of the sites that was studied, 44.5% of the women who died had not attended antenatal care. That's actually a big pointer to the importance of ANC. Tell us a little bit about how you think of the importance of ANC and maybe what's happening in your facility in Dub.
Thank you, Elvis. And I want to thank Noella for the excellent presentation and the work that Noella is doing. I do have the doctors at Grace Garden Hospital in Dub. They are on this, they are on Zoom and with us. So ANC is very, very crucial. And what Noella is doing is what, when I heard Mr. Turker talk about peace, even with all the challenges, we believe that going to all the villages, getting women to come for ANC is not easy. I think it was this year, we had a pregnant woman give birth in Dub around our hospital and dropped that baby into a pit latrine. She was almost beaten to death before she was rescued and the baby was brought to hospital. I think Dr. Noella, I think she was sent to regional hospital. And when I got the message, for me, it was just listening to you and all the statistics. We think about postpartum depression, what she was going through, and of which the people thought she was crazy, and they almost even beat her to death. Just gave birth. And so you can know if you take the environment where the hospital is and also the challenges, that we still believe much in witchcraft when we don't have the right care, and different things that they might have been talking about her. And with what Dr. Noella, you are doing, I'm just looking forward. That is why I made sure to have them to join this Zoom, because we find ourselves in an area where education, awareness of health information is extremely lacking. And I just want to commend you for what you are doing. We do our best to send out we do have community workers, just like she said, and even having our nurses to do visitation in houses around the hospital. And I believe that collaborating, as she said, towards the end, it would be the best thing for us to actually continue to decrease the maternal mortality. So, I mean, this is really wonderful, and just want again to commend you for what you are doing with your team. Thank you very much.
Yeah, thank you very much, Dr. Samuel, and thank you for all the work you're doing back in Cameroon. I would hand over to Dr. Brian, who is going to moderate the question and answer session. Please, if you have a question, you can use the hand icon to raise your hands, and he will provide you time to ask your question, and Noella will provide a response to your question. I think this is going to take us to the next 30 minutes before we wrap up the session. So over to you, Dr. Brian.
Yeah, thanks, Elvis. I also want to just recognize that there are lots of experts in this town hall today. The gynecologists and obstetricians who have many years of experience as well in the field, and it'll be great to hear some of their take as well on the subject of improving maternal mortality numbers. There are public health professionals here as well that have lots of published expertise in maternal health. I in particular I haven't worked on maternal health in particular, so it's not a domain that I can speak much into, but we do have lots of people here who have enormous published expertise, and I would like to invite some of those as well to contribute their input. I do see Dr. Ombaku is in here as well, and I'd really like to welcome him to give a few words. Dr. Ombaku is an obstetrician and gynecologist in Bamenda, and I think he has had a lot. I think Dr. Mono talked a little bit about his research, but he has done a lot of work to improve the burden of this problem in Cameroon, and I think his work has had long-standing impact across Africa as well. So, Dr. Ombaku, if you have a moment to share your thoughts on the subject. Dr. Ombaku.
Yeah, thank you very much, Doc, and good evening to everyone. I want to really commend Dr. Noella for the wonderful work she has been doing in Cameroon and all over the world. You know, when you go online, you reach everybody in the globe. And as Dr. Kwate said, education is a very important thing. Much of the work I did in maternal mortality was focused on educating the healthcare providers. And as Dr. Noella said, there are very harrowing stories you hear when you train this staff. We had a project where we train healthcare providers in all the health districts in the Northwest region. We went to their districts and trained them. And there's this story of a guy we trained in Cambe from a health center. He told me that when I did the presentation on preeclampsia and eclampsia, the guy confessed that he had a patient who had a seizure after delivery and died, but he never knew what exactly the patient died from. So the guy had no notion, no knowledge on pre-eclampsia and eclampsia. So these stories are actually there, and the healthcare providers have their part to play to train them. But also there is this issue about the social aspects of the causes of maternal death in our context, which is gaining ground. The effect of this, our pastors we have now. Many cases I've seen who had complications or who even died, the pastors and their belief in God played a very big role. And that's why I always tell my patients, when I say, Madam, your pregnancy is not going well, you need a cesarean section. Each time the patient says, no, doctor, God forbid, my man of God, that's a warning sign to me. So the maternal mortality has a lot of factors that we have to talk about, and training is very important. So I really want to commend Dr. Noella once more for the work she is doing, and to say that we are here, all of us. Dr. Forte, who is also a colleague, we are here to support her pro bono in everything that she thinks that we can support her in to help to curb this problem. Thank you very much.
Thank you very much.
Yeah, thanks a lot, Dr. Mbaku, for sharing those comments as well. Those were really, really heartfelt. I would like to also invite Dr. Forte Ascensius as well. Dr. Forte.
Hello, good evening. Thanks, Brian, for inviting me. I want to say it was a very inspiring presentation. Thanks to Dr. Noella. I know of the work she's doing. I've been following her. I used to work at the regional hospital, so I've been following her keenly, and I've been giving some support in the background to her programs. I think maternal mortality, like I said in the chat, is something that to address it, it really has to be multidimensional. Education, yeah, it's one of one method of doing health promotion, which is also a key. I think that if we look at the causes of maternal mortality, cultural factors also is very important. Like there is this story that I usually say that an NGO went and constructed boreholes in a locality in the north, and what happened? The people were not using those boreholes because what was the problem? Those people, those families, they live in huts, and the only moment where the husband and the wife, they can get together is when they send those children to go 2 kilometers, 3 kilometers away to fetch for water, that they can have some quiet moment. So what was going on was that they told the children that no, don't use the boreholes because it's not good. So that's just to show how other factors can affect a good project, you know. So I think that maternal mortality, it really has to be multidimensional. We need to educate, and we need to we need to go down and understand the perception of the people in the villages. We really need to know what they are thinking. What is the hindrance? Is it a cultural issue? Is it that they prefer to deliver at home? And why do they prefer to deliver so much at home? And then we can now address that, use other educative methods and address that. I think that's my thought about maternal mortality. Thank you.
Yeah, thanks a lot, Dr. Ascensius, and it's so great to hear from you again, and thanks a lot for all the work that you're doing in this field as well. And if you have any questions, I'll invite you to, you can raise your hand and ask, or you can put your questions in the chat as well. And we'll try to monitor those and try to ask Dr. Noella those questions as well. But I just wanted to, before I hand it over to Crespo, I would like to start it off and ask you, Dr. Gwanyama. First, congratulations for your awards, the Aviva, I hope I'm pronouncing that correctly, the Aviva grants that you received. I hope you receive more of those sorts of grants and funding support to help the work that you're doing. But I was wondering, from your experience, what are some systemic changes that you think need to happen in Cameroon for us to see an improvement in maternal health overall?
Yeah, that's thank you very much for the question. And one thing I would like to, if we have to change systemic, that's why I spoke about universal health coverage. I think this is really one of the main things that if it is really put in place, and especially targeting maternal health, I think it's going to be really helpful, because from my experience too, and what I got, because from the Mandela Washington Fellowship, when we went there, we had the opportunity to work with other doctors in this maybe like high setting environment. And when I discussed with him, he told me that when I was really curious to ask that, is there a woman in this, maybe in their setting, where they really see that she is pregnant and she's not able at all to even take care or maybe go for one visit. For the way he first of all looked at me, he was like, so it happens because their own uptake rate was, I think he said around 95 to 96% uptake rate of ANC. So there they have this Medicaid, even for the least people, they have those kind of ones that take care of the least people. So if we can have that kind of system, and I think that's what the universal health coverage is actually coming for. Because if any woman actually knows that, okay, if I get pregnant, I can follow up my pregnancy correctly, then that's the best thing. So subsidizing or reducing the cost of antenatal consultation by all means, and even maybe the universal health coverage for it to cover it completely. I think that's the systemic way in which it can help. Thank you.
Yeah. Thanks a lot. We had the minister come here several months ago to talk about his vision for universal health coverage. I know we still have a long way to go in Cameroon, but I hope. And he talked about his vision to incorporate maternal health as well into that program as well. So I want to hand it over to Crespo. Crespo, take it away.
So before Crespo's question, Brian, can I just say something? This is to Noella. I know you in the United States, they presented you a very good picture, but I want to tell you the truth is that I work here. There are many others. If you go to DC, this is where we talk about disparity of healthcare. And you look into, DC is a very good spot to look at. You look, that's why the statement from Ashantius and Ombaku saying it's a multifactorial problem is very important. If you look at DC, even in the middle of United States, there are population groups where the maternal mortality is similar to Cameroon. You will not believe it. And that is what is driving it. The reason is because there is real access to healthcare is a very complicated problem. And if you stay in Delaware, you will not be able to see that in a white community. In DC itself, there are white populations where no woman is dying, and there are Black populations where the maternal mortality rate is as equal to Africa, where having insurance at times doesn't mean you're going to access those hospitals. And at times, even telling people, some people don't even know about it. I just wanted to make that comment because it's a real issue here, which I am advocating for disparity of healthcare. And when people say it doesn't apply here, it does. And just looking at statistics in areas like DC, in areas like in the Bronx, and in areas like in Brooklyn, comparing several different groups, you can see that disparity, which I just wanted us to know that it's not only an African problem. It's better solved here, but it's still a problem. Even when we migrate over to this country, it becomes a problem still in our community. Thank you.
Yeah, I completely agree. The issues of health inequities are deeply rooted, not only even in the United States as well, and even in Brooklyn, New York, as Dr. Mono mentioned. It's a very big issue as well. Crespo, over to you.
Yeah, I deeply understand and agree with what everyone has said. I also just wanted to salute and thank Noella very, very much for the work you've been doing, and Ombako for adding. I just had a quick question I wanted to ask, because 7 years ago, I used to work in one of those hospitals, and I was seeing 40 women every Tuesday and Thursday for antenatals. I had my own way that I was using to be able to convince them to come, but I'm just curious, how are you doing with religion? Because religion was almost always a central factor where the women, if they are very late, they'll tell you like, or they're dealing with their pastor or their family is praying, or just that kind of belief, and then trying to put science aside. That's the first one. And then number two question is, how do you deal with it when they get to trust someone in the community better than you, who is an expert, who has done all these years of education just to know the things? And then most of the time, they would never agree to what you're saying. If you say something, explain to them well, they would agree in front of you as if they've really heard. But once they go out there and then that friend that watched over TikTok or Facebook saw it, they'll just say, so because you're using TikTok and you're using Facebook, and I know that like 80% of some of the stuff that goes on TikTok is absolute gibberish. So how are you trying to deal with these women who are coming with these situations? Because it was a little tough for me, to be honest.
Yeah. Thank you, Dr. Crespo. It's nice to see you again after a long time. Yeah. So one thing, especially concerning pastors, there was actually one case which that time I was at the maternity section and she came, we had to do a cesarean section. And the pastor was there praying and saying that, no, everything is going to go on well. What I did, I called her and the husband. There's one thing, maybe my own strategy, which I use. It's like, I'm just so blunt about the complications. So I don't mix my words when telling you that your child is going to come out maybe like a vegetable. You see that your child at 6 months, at 8 months, the child is not walking. Or maybe you can start bleeding now and maybe you die. So I don't mix words. I just tell you straight. And I tell you that God gave those people to preach the word of God. And they also gave us wisdom. So I tell you, I say, God gave me the wisdom to come and teach you this. So I use that and I'm so blunt about it. So I don't even mix words. Then secondly, how do I convince other see about women who maybe believe people at home and maybe you, the physician? It's still the same thing. I tell them that you hear things from, and the first thing is, how do I get to it? I know what in social media, for example, when you want to put like for example, your thumbnails.
And your thumbnails,
yeah. Your thumbnails, yeah, your thumbnails. You put what they want to hear, and they're going to come there now and hear what so you go into them and you use what they like. Yes, you use what they like and you tell them. So there are some strategies. That's how I do. So I just tell them that, okay, I don't want to get pregnant now. There's one that I made on menstrual cycle, how to know your safe day. So there I just said, I don't want to get pregnant now. I don't want to have an unwanted pregnancy. So that is what is going to strike them to come like, hey, my God, I'm in in secondary school and I don't want to get pregnant. What should I do? So I come now and listen to the doctor. So I use their words, I get into them and actually bring out now the fact and tell you that, okay, this is what you have to do. This is what you have to do if you don't want to get pregnant now. So better follow it. So I tell them straight. So that's the strategy I use. Thank you.
Good job.
Yeah, thanks, Crespo, for asking the question, and really thanks, Noella, for your insights as well. I think my key takeaway is there are some very key cultural factors to consider as well as we're having this conversation. Yeah. Dr. Kate, over to you.
Thank you so much, Brian, and good question, Crespo. Brian, you actually asked my question that I was supposed to ask Noella, but I'm going to ask another question related to when you were talking about pastors, because those are also my colleagues on the other side, if I change my hat. So
nice, Kate.
So
l'anglais c'est une bonne langue. Nous sommes deux. Mais
okay, thank you. So how do you, I mean, you've just talked about how you deal with those cases. What do you think about directing a particular training towards these people? Because you're saying it, Dr. Mbako is saying it, and I'm sure many other gynecologists or people who work with pregnant women, we say the same thing from our religious leaders. I would not say only pastors. And Crespo, you cannot also really control where someone puts their trust, right? Because those relationships are formed, you know, months, through months and years, even prior to us meeting these people at the hospital. So what do you think about that, Noella? I just wanted to get your
Yeah, I think I thought about it one time, targeting maybe religious leaders, especially including to like the imams and all that. So I thought about it to really include them, educate them on. Then there was one time that we actually did it at the Pope Baptist Church in Damokong there, where I actually invited the pastor of that church. So especially when I spoke about this premarital screening, so there are some things that, you know, some people, especially when they have this AS and AS, they say no, they can still get married. So he actually expressed to me that some people don't actually know that difference. And when they say, maybe people cannot get married, you start saying that no, God is going to help you. So he actually attended it, and he was so impressed about this. So that was what gave me the idea that, hey, it means that we can target these people. But I think I can work with Dr. Asensius and Dr. Umbaku. We can see how we can target that, because it's actually a problem to be, because one thing we should know, one thing I always tell these women is that we are not God. And two, there are times that even if we don't do this CS and you still deliver, because at times there you can carry this woman to the theater. There are cases that they take to the theater and she delivers in the theater bed. So I still tell them that this is the situation, but if you still believe in this, but know that it can still happen this way, but I tell you my own medically, that's one thing. So if we can actually target these pastors and religious leaders, I'm going to work with them and see how we can actually do that.
And just really to add to that before, Brian, you take it away from me, because, you know, I mean, the basis on which most pastors, for those who are Christian, I don't know, for those who are Muslims or those who follow African traditional religions, but they would tell you, you know, quote scriptures around the Hebrew women and all of that stuff, which has nothing to do with me as a Bamileke man, as my Bamileke woman as well. And it's a real theological fallacy. And I mean, if you ever want to engage in such a training, I would be willing to associate with you, throw more light on the theological meaning of that portion of scripture that we have completely misinterpreted. And the more we educate, you know, faith leaders, pastors, and mostly the women themselves, and empower them to know what that means, then they can make great decisions for themselves.
Very true.
So thanks a lot, Katia. I thought that was a really excellent suggestion to engage pastors and faith leaders in this effort.
And just to add, Brian, the town hall will be willing to help facilitate and financially support that session. So reach out to us. I think it's one of the things where I would tell you this is one of I've heard it across from all the doctors who are working in Cameroon. All the gynecologists have said the same thing here. You have said the same thing. So I think it's a problem. And Kate, being a doctor, public health expert, and also being a pastor can be a big help to you. So this is part of the town hall moderating system. So sorry for interrupting, but we are willing to actually sponsor such a whole seminar and training, even if we can start in Bamenda. So reach out to me, we'll see what we can do about it.
Okay, thank you.
Yeah, let's shift gear to Dr. Samuel. Dr. Samuel.
Thank you, Brian. Just to follow up, Dr. Kate, my doctors in Dub will be calling you also, because we're facing the same situation. I have Dr. Santana, Dr. Douala, and Dr. John Paul on. And for Dr. Noella, my question to you is more on the demographics of your audience. Most of them, are they mostly around the Northwest region? Are they mostly around, like, do you have many coming from the Facebook? Or is it nationally, like all over Cameroon? And my second question, you talk about doing campaign. How often do you organize ground campaign? Or are you mostly just on YouTube, Facebook, and TikTok? Thank you.
Okay. Okay, if you, let's say concerning social media, first thing, let's say Facebook. Facebook is where maybe most of your friends are like connected and around you. That like, let's say about 60% of my audience on Facebook is the Cameroonians, because it's like your friends around, yeah. Then on other social media platforms, like Elvis was saying, most of my views that people too from African countries, even in the United States. I have people from the US, from the UK, who come and consult me through online. So it's a broad view. And like I said again, the time I had the live video with the live show program with Dr. Dob Gibapiso, we had people actually from Bamenda who attended, and they came and consulted. And even one who came from Bafoussam, she actually left from Bafoussam and came and saw me, and went and saw Dr. Gobigma, and she benefited from a laparoscopic surgery. So wherever they are, I see the ones that are around, I tell them they should come to the hospital because it's better to see a patient. So those who are out, I just give them like counseling and maybe tell them, okay, go and see your doctor. This might be the situation that is happening. And once you see your doctor, this is what is likely. So that's how I do. Then if it's for online, on-site campaigns, I do them all the time as need be. I do not want to put a lot of those pictures. I've done a lot of on-site campaigns. So it's just when I have something, when something just pops up in my mind, like, oh, we have to sensitize people on this. We start seeing how we can do. Then even like if we have fundings, if I apply for any funds and I'm granted, we carry out the on-site campaign. So I do it according to the way it comes.
Thank you very much.
And just to add to that, I have over 30 volunteers with me that are working. And what I do is that I don't only train them to go into the community. What we do is that we do capacity building for those volunteers. We give them leadership programs. We give them how to design flyers, because you don't know what everybody's own, maybe like their own gift. So we also train them, we empower them also on themselves as leaders. So they're not just volunteers. That's one thing peculiar about the people I work with. So they are always ready. If you have any campaign, we did ones where we're sharing menstrual kit buckets and pads to people. So we do most of those things on ground.
Thank you very much. We're looking forward to working with you and having you come to Ndop.
Excellent, excellent, excellent.
Yeah.
Well, thanks. Jerome Shite.
Sorry, I'm trying to unlock. I just unlocked. Hi, Dr. Noella. Hi, this is Jerome Shite. I'm a doctor in nurse anesthesiology practice in Buffalo, New York. I'm actually at the hospital now. Sorry. Wow. So I want to thank you immensely for what you're doing. I actually was trained as from the Brevet School of Nursing and Midwife in Bamenda prior to coming to this country. And I did some deliveries myself forever coming here and then specializing in anesthesia. The question I have for you is this. You talked about the insurance policy for women particularly. And in that domain, I just have this question. When I grew up, my mom, who used to be my Mufi, ran the health, the maternity in Dom, right around that maternity hill that we still call built by the Germans. Long ago, that still exists. I don't know how it is now because I haven't been there for 18 years since I came and then came back. The war was there. I cannot. Dr. Samuel, thank you for what you do in Dom. That's where I was born, and That's where my parents still are. So, ma'am, my question is this. When that, in those days, when we were born, these maternities were actually run by these midwives, and prenatal care was provided by these maternities. All the women needed to do was to pay 600 francs for their maternity card. And they had to go back home with milk and all these things when they came and they were deficient of tablets. Now, all those policies must have crumbled if today they cannot have even anything. But have you taken time to look at how that policies that existed before then that provided this free prenatal care for women were run? I know that some of them came through WHO and other organizations like the GTZ, because when I worked at Northwest Special Fund for Health, that was one of their focal points. Have you taken time to do this research and look at how this ran, and then maybe provide your statistics on how the current prenatal effects are going, affecting the women, and see how you can put this forward to maybe the provincial delegate, or from the, let's say, from your chief medical officer to the divisional medical officer to the provincial delegate, and then maybe with your focus taken into the minister himself, and see whether they can actually solicit for the WHO or whatever, or the GTZ, to see if they're providing funds for HIV. I know GTZ still was doing that. They can still look at means of subventing this maternity ANC care for the pregnant women. So maybe if you can look at what used to exist then and that worked well and how it got in, and then maybe pivot and then see if you can also do an application, because when you show them the statistics and what you're doing, which is a domain that affects many women worldwide, maybe you could still be able to punch that hole and refocus that direction, and maybe they could ever bring back that system that existed before for women.
Okay.
Thank you.
Well, thank you very much. I think I'm going to look into that, because I think there was one organization that's Comisud. I think there was one day that I heard about them bringing women to do ANC for free, and they're going to take care of it. I was so interested about that and so happy about that. But I think it was 1 month or 2 months after they said the project is no longer there. So I was like, but I'm going to check on what worked before and actually see how we can push forward with this. Thank you for that.
And I have one more thing to say to you. Professor T, the director of the CBC Health Board, I still do a lot of things with him. I still work with him. If you can get in contact with him, he has a magic key with most of these international organizations, and even with the Minister of Public Health himself, and also the embassy, United States Embassy, and WHO. He actually runs a lot of program with WHO, the Ministry of Public Health, and the embassy, the embassy of the United States also. So Professor T. Pius, the director of the CBC board. Thank you.
Okay.
That's super helpful. Thanks a lot, Jerome. I want to hand it over to Frida Mbolo.
Hello. Good evening, everyone.
Yeah, good evening.
Yes, we hear you, Frida.
Thank you for giving me the floor. And I want to thank Dr. Noella for her presentation and for the work she's doing. It's very interesting. You know, social media is a milieu where we have a lot of information being shared, and I'm happy that you took this initiative to share your experience with others. I just wanted to make a comment with respect to the man of God and as a hindrance to maternal care. My experience in working in Kumba, a good number of women I've come in contact with I remember I had an experience where I saw a lady. The diagnosis we had then was acute fetal distress, and I told her that we had to do an emergency CS. The lady rebuked me. Said, I rebuke you in the name of Jesus. I was confused. I looked at the lady coming to Kumba, young doctor with no experience in 2018. I was just so lost. I said, how can I help this woman? And what I had to do, I saw she called for her pastor, she called for other people. The person I approached was the pastor. I told the pastor that this lady came here. I've never met this woman before, but I believe it's God who brought her. So I explained everything to the pastor, and it's a pastor who actually convinced his Christian about the CS. And another step that I've used is that in the churches, in the church where I attend, we have a women's meeting every week. So I educate them about setting the importance of CS. The issue is they'll tell you that they believe their report, the man of God will tell them that don't believe the doctor's report. But when you give them when you educate them and demystify the thoughts that they have around the operation, the CS and everything, with time, they'll tend to trust what you're telling them, and they'll actually give in to the care. So when the patient, I think that the way forward to solve this problem is education. And the Catholic Church, the Catholics, the Baptists, the Presbyterians, they don't really oppose to cesarean deliveries. The main problem is the Pentecostal churches. So if you're doing education, it's good to focus in that area, because I know a lot of these pastors, all of their children, all of their wives gave birth through C-sections. But when it comes to the patients themselves, they choose to believe in their man of God. So it's not like when you tell some of them that your pastor, his wife gave birth through C-section in this hospital, they are actually surprised. So it's good to inform them. I think that education is going to play a big role in this particular aspect. So that's just what I wanted to share. Thank you.
Thank you. Thank you.
Thanks. Did you want to make any comments on that? Oh, I think we've talked at length about the implications of involving the religious sensitivities around the subject as well. Dr. Mona, I see your hand is up.
Yes, I have some comments and I have some questions too. My first comment is really about leadership and whom patients do believe. That was a very important aspect that was raised by Crespo. And truly being a leader and whom the community leader, the true community leader is actually earned. At times, we may not be happy with who is calling and pulling the shots, but that person needs to be identified. I worked in Mancon, in Tinkag. I think a lot of you, those who are in Bamenda, will know that I worked in the regional hospital, then I later worked in Tinkag. And my first question was, who pulls the shots here? Whom am I supposed to contact if I want people to change behavior? After my investigation, the Mancon people may be here, I hope nobody gets angry with me. I realized that the MAF4 of the palace was the person calling a lot of the shots. And once you got the MAF4 on my side, she could tell me whom to even choose in the different communities. And that is how we got to the aspect of influencing everyone to get water. I will tell you one thing, because identifying the leaders, some of them may be the pastor in the church. And we need to know these community leaders who influence people, who are influencers, so that we can target them in trainings and involve them in anything that we have to do, vaccination programs, maternal mortality programs, introducing new education in the community. If you don't have them on your side, you're wasting your time. So identifying them, this is just a general comment from what my experience was in Cameroon, is important. The next thing really is more about everything we do, sustainability. And I think back in the Jerome said a lot of programs were done in Cameroon. That has been one of, I can recall because my mom did nursing and midwifery, and I used to see all those books that were sponsored by UNICEF, WHO. Back in the days, there was just so much funding for healthcare and targeted towards maternal healthcare. And when the world went to a big economic crisis, especially African countries in the 90s, the early 90s and the 80s, a lot of funding dried off. And healthcare was one of those departments that got really affected, the pillars of healthcare. Right up to now, Cameroon doesn't even still provide up to 5% or not up to 15% of its GDP on health. Most of our healthcare budget comes from foreign donors. And this is some discussion we need to have at policy level. We need to be able to have programs that are sustainable over time. As Noella told you, she heard about a program just few months into the program of giving free maternal health, the program dried out before even getting to the point of doing that. So we need sustainable programs. We need advocacy as much as we need education. Now, when it comes to the delays, this is where my question is, Noella. When you're studying this whole maternal mortality thing and trying to influence women, do you always think about these 4 delays? I know there are some of them that we can easily affect, which that's what you're doing. To seek for care is the first thing. Seeking for care comes with, and I would go to my next question, which is more about the statistics that we present. Like we showed that Bamenda was the highest area with maternal mortality. Are we truly picking out, not the highest area from the data that we saw, like most people who died were around from Bamenda and womb. And you realize that those areas have hospitals. The 3 big regional the 3 biggest hospitals that were built by the Germans, the Bamenda Regional Hospital, the Cambe Hospital, which is now Regional Annex, if I'm right, the womb, they're all the same structure for those who do not know. They build them the same infrastructure if you've been to them. And you would realize that a lot of these women still die at home. Are we able to pick up that statistic? Is this statistic hospital-based or is it a community-based statistic? Are we truly representing, when we have that data, does it truly represent the state of maternal mortality in Cameroon? And how do these 4 delays really affect maternal mortality? Seeking for care, which I think you're doing a wonderful job there. There is also the aspect of reach help. In order for you seek for care, but if I'm living from Jinkwa or from Mwa, and I want to drive over to Womb or to some place, and I need someone to carry me on the way, there is no roads, the woman needs to be carried by multiple people in order to reach the Womb Regional Hospital, the Womb Hospital, in order to get surgery, maybe from Dr. Ombako, who was there like some 10 years ago. How do they reach there? Now, getting into the hospital, our hospital attitude. How do we receive women? Do we have a transit where women cannot stand on lines? Women can go directly. How do these hospitals behave when women come there? And the last part is infrastructure. I'm going to tell you my story still. In the regional, I was transferred from regional hospital to Tinka, and I realized I had a maternity with no water. No water at all. There was no water in the whole of Tinka, the whole of Mancom then, in the area where I was. There was no water in the hospital, no clean water. How do you do safe delivery when you don't have water at all? How do you do surgeries without water? How do you do anything without the access of clean water? I'm not even talking about staffing. I'm not talking about equipment. I'm talking about fundamentals. The basic fundamental of what health, hygiene, and healthcare is supposed to be was lacking. So these are just reflections. Some of them are embedded with some few questions, I know, but it's just to say that you're doing a wonderful job, but I just wanted your reaction about where you can influence. Some of these things we need to bring all the ministries together. We need to be able to get the ministry that is in charge of roads. We need to get the ministry that is in charge of infrastructure. We need Ministry of Mines. We need Ministry of Water and whatever. I've forgotten some of those names of those ministries. So thank you very much.
Thank you very much, Dr. Mono. Yeah, those are really key strategies to actually improve maternal mortality. So those are, that's why at the end I said collaboration is the key, and you can't solve everything. First thing is you collaborate with all other stakeholders. Then, especially like reconstructions of health facilities, training new personnel and putting them all there. So those are the basic things in which can really help to promote maternal mortality. And thank you very much for emphasizing, and we'll see in what way which we can help to include those other aspects, not only targeting maybe like antenatal care. At least we'll see how they can actually reach the hospital fast. Thank you.
Yeah, thanks, Mono. Thanks for always giving very deep insights into these issues. It's really great. We'll take one last contribution from Osric Nafti. If you can just tell us where you're calling from as well, that would be helpful.
Can you hear me?
Yes.
Yeah, so Osric Nafti, I'm an obstetrician and gynecologist by training. I'm now a senior consultant in maternal and fetal medicine. So I trained in Nigeria. I moved to the UK for my postgraduate training, was a consultant for many years. Now I practice in the Middle East. So I'm presently in Doha. So I've been listening in with some keen interest. Obviously, I left Cameroon many years ago, and I didn't really practice any medicine in Cameroon, but I have some experience. A colleague who's done some incredible work on this very aspect that we're discussing. And so it would be a shame if we don't leverage experience from quarters that are very similar to us in many ways. There's a multitude of problems. I mean, in the UK, and one of the things that has not been mentioned, we've touched on it in some way, but only partially. There's the issue of data, which we just talked about, and how reliable that data was. But I think more importantly is actually, knowing for a fact what the mortality is and what are the causes of the maternal mortality. And one of the ways for us in the UK, there has been an ongoing audit of maternal mortality since the 50s. This is the longest audit of any health outcomes in the world. It was called the Confidential Inquiry into Maternal Deaths. Years. And what it did was identify the major causes of mothers dying. And then once you have that data, then you can work putting in place measures that address the issue. One of the most recent reports, the report looks at mothers and babies. And in fact, interestingly, you were talking about disparities in healthcare. And that's a real problem. This recent report that just came out this week, or certainly this month, shows still disparities in outcomes between Black and minority ethnic women and white women across the board. So it's not just about social status correction, there's still disparities. So it's more complicated than just the fact that of access of care or whatever. There's more complicated stuff. So my point really is, I have a colleague who's based in Ondo State in Nigeria, and they developed a system which over a few years led to a 33% reduction in maternal mortality in their state. It's well published, and I can share with whoever you give me their email. So I'll try and get the papers and share them, because and I'll be happy to put people in contact with Dr. Lawal, who's a very good friend of mine. And I'm sure he'll be able to sort of discuss his experiences, and we will do that. One of the things that they did in Ondo State was a lot of women were delivering in churches and in the community. And so what they did is they brought in all the sort of attendants into the system. So they trained them. In terms of recognizing risk, it's probably about risk identification in terms of what the usual, okay? Who should I be referring on to a hospital? They also provide a state system of ambulances, in terms of bad roads. So ambulances that were adapted for the local community. There was a phone line which was about reporting maternal deaths. There was data collection. So it was a whole system of measures that resulted in significant reduction. I mean, sadly, obviously, with politics, once the state governor who was the champion of this moved on, the emphasis and the funding sort of wasn't as it was during the trial period. But Ondo State is still an example in Nigeria of where you have a much lower maternal mortality compared to other states. So, you know, we can, and I'll be happy to put you in touch with Lawal if anyone's interested, because I think that actually would be quite useful to us in Cameroon.
Yeah, thanks a lot, Dr. Ostrich, and thanks a lot for joining, and thanks a lot for sharing those very important insights. I think Dr. Ostrich dropped the link to the Ondo study in the chat for those of you who can look at it. I just had a chance to glance through the paper, and I think in summary, it's very reticent of what we have in Cameroon as well. And I think one person talked about the issues of underreporting. I think that was Alberic, which might be an issue. So there's a lot of other cases of deaths that are certainly not counted, particularly in the interior and in the rural areas as well. And it looks like, based on the study, what I'm seeing from the Ondo report, it looks like Ondo, most of the deaths in the Ondo state in 2013 were linked to mothers not being linked to any formal health facility. And what they kind of try to do from the study, my understanding is they try to link the traditional birth attendees with a health facility. So they did some sort of formal training, and it led to a significant drop. And I heard you mention about a 33% drop in the maternal mortality. So that's really, really impressive. Be curious. I think would love to connect with this doctor you mentioned and see how we can work together and learn a little bit more from the approach and what they've been able to do using this initiative to leverage. Yeah. So thanks a lot for those.
Absolutely. I think Lawal he'd be certainly most interested in sharing his experiences. He's very experienced in matters of maternal health. I mean, Ondo State is very similar to sort of the North in terms of the issues, the geography, the healthcare facilities and stuff. So, you know, I mean, so it will not be too dissimilar what we can learn from them. And I'm sure he'll be happy to share.
Excellent. Yeah, thanks.
You're welcome.
Yeah, thanks. Yeah. So I think we are close to the end. So we'll try to have a round with the moderators today. I think it was a very insightful discussion. And Dr. Noella, as Dr. Mono mentioned, I think the town hall will be reaching out to see how we can help to support this initiative and how we can lead to more community engagement and in terms of resolving this issue back home. So I want to take a round with the moderators. Start with Elvis, maybe. Elvis.
Yeah, thank you very much, Brian. And I was smiling when Dr. Ascensius told us a story in the North. I told myself that my kids are fortunate that they were not at that era in the North. They would have carried water until they get to understand what it means to send them for a long distance to fetch water. Sometimes you need that moment. So it's been a really, really wonderful presentation by Noella. She started by painting a very emotional picture of what maternal mortality really means, and she let us understand the definition. And it was interesting to know that the global maternal mortality statistics still stands at 210, and that every 2 minutes a woman dies, giving birth. And 99% of this, she said, occurs in developing countries, and that most of these are preventable. And she said women of childbearing age represent 23% in Cameroon. And among some of the districts in the Northwest region where she practiced, she said Uku and womb were the two health districts after Bamenda that accounted for high maternal mortality in 2022, which is really a very important thing to note. And she cited a study that was conducted just to look at some of the pointers of comparing the impact of ANC to maternal mortality. And we saw the case of the Central Hospital, where 44.5% of women who died registered as maternal mortality were those who had not attended ANC. So that's just to tell us the importance of ANC. So Noella actually pointed some direct causes of maternal mortality, which includes hemorrhage, sepsis, obstructive labor, and hypertensive disorder. And she walked us through some of the work that has to be done as far as prevention is concerned. But then she shared us a very emotional story of what brought her into this space of educating women on pregnancy and pregnancy outcomes. And that led her to start her YouTube channel, which just in less than, it's not up to 2 years, she's already had 900,000 viewers on her channels, and with about 20,400 followers on YouTube and about 29,000 followers on TikTok. This is amazing to see within a short time how she has had all these followers. And we also, the result of that were some of the awards she has had, including the Mandela Washington Fellowship Award, which she had recently. And I always like to, do a summary of our presentation by taking one of the quotes from the presenter. And the one that caught my attention is when Noella said, "If every woman knows what pregnancy is all about and what to expect, it will be a very great beginning for a better future for women." That was how she ended her presentation. But of course, in the interaction and conversation, we also identified the needs to look at cultural factors of maternal mortality. And we all agreed that pastors and religious leaders could become champions in improving or promoting ANC and other education around pregnancy if they have the right education. And I think Dr. Kateb is a resource person whom we look at into seeing how we can conduct this kind of education with religious leaders in the Northwest region as a pilot, just to see how this can improve education of women and encourage women to seek ANC during pregnancy. This was what I was able to get, Brian, and thank you. It was really a great pleasure having Noella on this presentation. Over to you.
Thanks, Elvis. That was an excellent summary. Dr. Kate.
Thank you so much, Brian. It's really difficult to say anything after Elvis has spoken. And so I would just rightfully say thank you, Dr. Gwanyama Noella, for your presentation and for your work. And thank you to everyone who has been on the town hall this particular evening. Thank you very much, Brian.
Much appreciated. And thanks to everyone for joining. We'll see again in 2 weeks. I just want to hand it over to the chair to give his closing remarks. Dr. Mona.
Oh, I just want to say it was a wow moment for me. It's been a very emotional roller coaster presentation where we have had a lot of real life stories. You know, as someone always told me, if you put people into numbers and you make them look real, people are always willing to help. If you just give people statistics, people may feel that the statistics are too big for them to make a change. That is why if you go into fundraising groups and you see I put a fundraising to help Cameroon, no one is going to put any money into it. If I put a fundraising to help someone who is crippled and I market it well, you see millions of dollars go into that. Because people just try to conceptualize how much their money is going to make an impact. I think today we had a real situation where we saw exactly how these real life situations are things that affect us. There are our mothers, there are our sisters, there are our daughters who are dying from maternal health. And I was happy to hear the input from multiple specialists who are here. We had multiple gynecologists, those based in Cameroon, those based in Europe, those who have worked in the UK, who have worked in the Middle East, where now there's a lot of money and they have a lot of policy and things going on. So, and even those based in the US. So it's been a very interesting presentation. I want to thank Noella for the wonderful job you're doing. and also encourage others who are here. There are a lot of great minds here. Don't hesitate to reach out to the town hall if you have a topic of interest that you want to present, and we would always be willing to provide the platform where we can bring out change to Cameroon. The goal of the town hall is to act as a platform where we can influence change, even from the diaspora. We can get those who are in the diaspora communicate with doctors who are in Cameroon so that we can work with each other to bring about change. My next point really of emphasis is to tell Dr. Noella that truly it's a town hall commitment, so reach out to us. Take your time, arrange a good session where we're going to be able to start a pilot thing in the Northwest where we can educate and communicate and talk to the pastors, talk to fathers, talk to the bishops, invite whoever you can to attend, because I think everyone, those are all community leaders. No matter what you do in the hospital, if you don't have the right leader, you're going to be in trouble. Trust me what I'm telling you. I have, even here in the US, I'm an oncologist. I work now, I used to work in New York. I work in Albuquerque. We have a Santa Fe syndrome where every woman who comes in from the capital, which is Santa Fe, with breast cancer moving here doesn't want treatment. They want holistic medicine. Still in the US, I want to tell you that they want holistic medicine and they are willing to fight you for it. But they come over to see us, but it depends, and we are trying to identify who are the community members, who are the ones shifting these decisions, making them being able to think the way they do. So it's very important. Don't think these problems occur only in Cameroon. Even where people are developed, humans are complex, extremely complex, even when they are educated. So I also want to thank all the moderators. I don't know where you guys get the time to organize and take care of all of this. You guys are big champions. Those who attend every day, let's keep doing what we're doing. I think if not of you guys, I would have given up long ago, if not of everyone who comes here. It all started like a joke, but it's here to stay. So thank you, everyone. And I think, Brian, we can have like a 15 to 30 minute parking lot discussion so that people can go around with their activities. Thank you very much.